today to tell you about that, because until you got that pharmacotherapy behind you, you probably wouldn't have listened to what I said anyway. But now that that is behind you, and I know you're preparing for your drug interaction exam, I do want to let you know how we're going to structure this one. The main question has been in regards to the last exam, which was completely open book and open resource. No, this one won't be quite that same format. We're actually going to give you 2 exams in one. There'll actually be 2 files to download from ExamSoft. One will be a secure exam, like the ones, for example, you take for pharmacotherapy, which will not allow you to use your other resources or to, switch to your browser or anything. And that'll be approximately 50% of the questions, probably about 25 questions. And it will be based on questions that your faculty have developed to be those that they use various ways of telling you what they expect you to carry around in your head versus what they would expect you to use resources to verify. Big Bold Blue, I think, was the most popular discussion that Dr. Misher used. But all of your faculty kind of told you which ones they felt like you would need to be responsible for and would need to know for things like the NAPLEX exam, which of course is definitely not an open resource exam. So it'll be 50-50. We'll start out with the secure exam, or the one that will be closed book. And then at the end of that exam, it will actually give you the password for the second exam. So again, this is something we haven't ever done before, but I think it's going to work out that way. All of your proctors will know that at some time after you have completed the first portion of the exam, you will open another exam, and you will then be able to pull out, your notes and your resources or other devices you use or whatever you do on the open resource. So it'll be about 50-50. The faculty have set up the questions to be based on whether it's something you need to carry around in your head or to use your other resources. So we're going to see how that works. I think it'll work out pretty well. Again, if you stick with what they told you in class as far as those things that you needed to commit to memory versus things that you would need to use other resources, possibly to give alternative therapies or things like that. So the exam will be next Tuesday, and I'll remind you via email. There'll actually be 2 files to download from ExamSoft so that you'll have both of them ready to go. So without any further ado on that, I'll let Dr. Misher introduce our speaker today, and we'll realize our notes ended for the exam with the exam last Thursday. And the very first one for that exam was the last one of Dr. Osai. Okay? So that covers that material, and it's listed in your syllabus in the schedule that way. But the material we're covering today and the material we'll cover Thursday will not be on this upcoming exam. Okay? Good luck.
All right, guys. So I have the pleasure. Let me just make sure you can hear me in Athens. Yes? Yep. Augusta?
Yes, we can hear you.
And Albany?
Yes, ma'am.
Okay, great. I have the pleasure today of introducing Dr. Bolina. She is one of our PJI-1, I don't know here, but she's not, pharmacy practice residents here at St. Joseph Candler in Savannah. So she will be covering women's health and pregnancy today for you during action.
Hey everyone. So like Dr. Misher said, I'll be going over women's health and drugs and pregnancy. Layout of this lecture is a little bit different than your typical lecture for this course. Instead of your drug disease, drug food, drug sections, I've split it up with pregnancy and women's health and then disease states underneath that. And also, before I get started, make sure you watch the pre-lecture because material from that will show up on your exam as well. So here are the objectives for this lecture. Make sure you're familiar with these and the content related for your exam. So to start off with pregnancy, Okay, sorry about that. So during pregnancy, you have an entirely extra compartment and additional pharmacokinetic and pharmacodynamic parameters to consider because there's a baby in addition to the mother. So drugs that are smaller in molecular weight are going to want to cross the placenta a lot more easily than larger drugs like your heparin or insulin. More lipophilic drugs can cross the placenta a lot easier, just like drugs that are weaker bases because fetal pH is more acidic. And then additionally, there's more plasma proteins bound in the baby compared to the mother. So drugs like warfarin will likely distribute more to the fetal side than the mother side. So all these considerations go into drug recommendations and how we see drugs act a little bit differently during pregnancy. So I'm going to start talking about more chronic disease states in pregnancy. First off is diabetes, both gestational and pre-existing. This is the complications at the top. Also left off preeclampsia, because I'll talk about that on the next slide, but that is one of the complications. So the ADA has certain recommendations in place. Of course, we're going to recommend lifestyle management for patients pregnant or non-pregnant. But then there's 3 drugs listed: insulin, metformin, and glyburide. Really, they all have very similar recommendations. One's not usually recommended over the other as far as guidelines go. How you determine between one drug over another is patient preference. Insulin sub-Q. Metformin, glyburide, or PO. However, the oral agents don't have as much long-term data as insulin does. However, you have a patient who's taking metformin at baseline, becomes pregnant, and they really don't want to inject themselves to treat their diabetes during pregnancy. So they may want to stay on metformin. They have a different mom who is completely okay. So it really comes down to patient preference, as all of these are recommended and other anti-diabetic agents aren't really used during pregnancy. So talking about preeclampsia, I went over this in the pre-lecture, so I'll just go over the prophylaxis during pregnancy. Use aspirin, generally 81 milligrams a day starting in the 2nd trimester, called birth. Keep in mind this is different than patients who don't have a preeclampsia risk. Aspirin is generally not recommended. So you'll hear me say this multiple times throughout the lecture: benefit has to outweigh the risk in order to justify drug use. So in this case, the benefit of taking aspirin every day outweighs the risk of developing preeclampsia in this population. Related to preeclampsia, we have hypertension. So of course we know if hypertension is uncontrolled, it can progress and lead to eclampsia. So I have 2 columns: drugs to use and avoid. I'm going to focus more on the avoid column. So you see ACEs, ARBs, are mineralocorticoid receptor antagonists, that includes spironolactone. The number of patients on these medications is a ton. If you've been in any healthcare setting, you know how many patients are on like lisinopril or losartan. So it's really important to screen your patients if they are females of reproductive potential and on any of these medications to rule out pregnancy, so you don't risk harm to the baby. And then your options for transitioning off of an ACE or ARB or other agent can include labetalol, nifedipine, methyl-dopa. Alternatives include diltiazem, clonidine, and even prazosin. Then related to that, hyperlipidemia. So many patients are on statins. I feel like everyone with some sort of cardiovascular disease who falls into any of the benefit group at some point is going to be on a statin. So of course during pregnancy, that is contraindicated. So you'll switch them likely to an omega-3 fatty acid, but really it just depends on how well their cholesterol has been managed and if they need therapy. Because if hyperlipidemia is unmanaged in pregnancy, it can lead to cardiovascular outcomes later on in life and preterm birth. So with that, that sums up our chronic disease states. We'll move into our first case. Take about 5 minutes to work through the questions, and I'll go over them after that. Any questions though before? Yeah, so take 5 minutes and we'll regroup and go over the questions. guidelines?
Yes.
Okay.
Reading.
Okay, cool. So let's go over the cases. So our case, HB, 33-year-old female who's having trouble managing her A1C with diet and exercise alone. So you'll have her past medical history, medications, and labs on your case. So I'll just jump into the questions. So she has a history of diabetes. What did y'all suggest for her diabetes? Let's ask Albany first.
Is she pregnant?
Yes. So how did y'all determine if she was pregnant? Anyone? No? Okay, so I'm hearing here in Savannah her HCG is positive. If you look on your case, the very last lab is HCG. So that's human chorionic growth hormone, and that indicates pregnancy if it is positive. So that's one lab to keep an eye out for if you're ever out reviewing patients. Okay, so now that you know she's pregnant, how would you like to manage her diabetes?
Initiate insulin therapy.
Okay, yeah, you could do that. Did anyone have something different? This can be any of the campuses.
I would first ask if she wanted to continue the pregnancy, and if she did, then I would ask her about metformin, if she would be comfortable taking a pill, and start around 500 milligrams, and then if she needed to, get her titrated up to 2,000 eventually.
All right, yeah, so you're taking into account patient preferences. Does she want an injection? Does she want a pill instead? So that's very important to consider. So yeah, our options, like I had on the initial slide, for diabetes, insulin, metformin, or even glyburide. And then did anyone want to start aspirin? Savannah? Okay, so I'm hearing some discussion. We do want to start her on aspirin because she is at risk for preeclampsia with her history of diabetes. And so we would start her on aspirin, 81 milligrams a day. And I also heard some concern of her blood pressure. Her labs, her blood pressure is 125/80, and with the new guidelines, that's a little prehypertensive, but the main point I wanted to make is she's diabetic, so we'd start her on aspirin. And then also just encourage continuing lifestyle and diet management as with any patient.
Dr. Molina,
All right, go ahead.
would you start this patient on insulin if they wanted, even though her A1C is only 9.3?
Yeah, you could, since she's pregnant, and that is one of the suggested agents, you could definitely start her on insulin if she was okay with doing sub-Q injection. So it's a little different than your non-pregnant patients where you usually don't see insulin until you tried metformin first or other oral agents, or even until their A1C is 10. So because insulin is safe in pregnancy, we can use it.
Thank you. Thank you.
Would you start on just like basal insulin?
So it depends on her blood sugars. I might try basal insulin just for the better control. And what have you seen in your outpatient clinics?
So typically, for our pregnant patients, we want a very strict A1C control. So usually for these patients, we want an A1C closer to like 6.5. And you want very strict control. So you don't want their blood sugars to be elevated in any way, shape, or form, and the goals are actually typically lower. for these patients. So the way to achieve that and to achieve such precise control is often to use insulin. So it's not uncommon. I would go with a basal first. But if there was any question about postprandial readings, then I would be very quick to add insulin.
I have a question.
Yeah, go ahead.
So I haven't brushed up on my pregnancy information recently. So how do we know that the patient has a risk for eclampsia or preeclampsia? Is it just because she has diabetes, or are there other risk factors that we need to consider?
Main risk factor. I go over in the pre-lecture, so be sure to review that. But what I've gone over so far has been, main point is she has diabetes, so of course she is at risk for preeclampsia with that history. Does that answer your question?
Yes.
You did? Okay. Did anyone else have questions? Okay. So yeah, watch the pre-lecture because I go over preeclampsia and the risks associated with it. That should answer a few questions. So, ready to move on to the next one? Okay. So do you have any additional recommendations for the patient's other disease states? Let's start with Athens.
She needs to be taken off her lisinopril.
Yeah, she's on an ACE and that's contraindicating pregnancy. What would you suggest instead?
Labetalin or nifedipine.
Yeah, both good options. What else? Was there another disease state you wanted to manage? Let's do Augusta.
Yeah. She should be taken off of the Crestor and started on the omega-3 fatty acids.
Yep, so she's on a statin, also contraindicated in pregnancy. Fish oils, as we know, are safe to use. Good option. So real good. Any questions about this concept?
I have a question about the fish oil. I think we learned that it mainly targets triglycerides, so are we just using this because it's our best option because she's pregnant, or is there another way to manage the LDL?
Yeah, so really most data points to that fish oils are safe to use in pregnancy. Data for the other agents it's not as clear. So it's really more of a risk versus benefit, and I wanted to present something that was a little bit more clear cut. I know fish oils do target triglycerides a little bit more, but it's safest. That's what we're going to go for.
Thank you.
No problem. Any other questions? Okay. So that was the first case. I'm going to now move on into more miscellaneous disease states or acute issues during pregnancy. Starting off with hyperthyroidism, note that preeclampsia is one of the complications for untreated hyperthyroidism. Drug therapy for this is a little bit different than just having a list of drugs that's safe to use. It's trimester based. So in our first trimester, you can use probol-thiuracil. Then second and third trimesters, methimazole is safe to use. So probol-thiuracil has a risk for hepatotoxicity if used later on, and then methimazole has a risk for embryopathy if used prior to the second and third trimesters. And very last, I have avoid iodine. Can anyone guess why iodine would not be safe in pregnancy? Ask here in Savannah. What? Yeah, so it's radioactive. Why is that a concern? Yeah, use your mic.
You wouldn't really want to be exposing a fetus to radiation as it's developing.
So iodine will not only target the mother, but it will target the baby as well. We don't want to target any developing organs and cause fetal harm. So that is a greater risk than benefit in that case. Now, the next topic is migraines and pain. This slide A little different than some of the previous disease states that I've gone over. So I have pain and nausea broken up in the use and avoid columns. Something that might contradict itself is ibuprofen is in the use column under pain, but then I've got NSAIDs in the avoid column. So generally in pregnancy, we want to avoid the use of NSAIDs. However, in a benefit versus risk scenario where the benefits of using ibuprofen, say a mom has consulted her OB, she's really tried everything else and that's the only option she can take, it might be safer for her to use ibuprofen than something else. But our general recommendation is that you want to avoid NSAIDs, including our aspirin. However, we know in our preeclampsia risk population, aspirin's our go-to drug. Then going towards nausea, you can see promethazine, compazine, and Reglan, also known as prochlorperazine or metoclopramide, are safe agents to use. And then our favorite, Zofran, ondansetron, is in the avoid column in nausea. However, with Zofran, you can use it if all other options have been exhausted. The mother's nausea is just unbearable, and of course her OB has determined it's safe. So that is really like a last line option, but generally we'll avoid. You'll notice that a lot with pregnancy. It's always going to be a risk versus benefit determination, and a lot of times if we're out in retail and a pregnant patient consults us for a recommendation, primarily going to say, has your OB given you a list of drugs that you can or cannot take? That's going to be their primary resource. And then also you can tell them what you know is generally safe and harmful and have them consult their doctor. And for migraine prophylaxis, propranolol has been determined to be safe for use. And alternatives include TCAs as well. So depression, this is another disease state where it's really all about benefit over risk. So with patients with depression, they have tried multiple agents before they have their disease state under control. So that's determining which drug therapy would be optimal for the patient and also safest during pregnancy might be a little bit different than your guidelines, but generally SSRIs, PCAs are safe to use, and then of course our first line is going to be cognitive behavioral therapy. That's same in non-pregnant patients as well. You're going to generally avoid paroxetine due to heart defects. However, in some cases it can be used if the benefit has been shown. And the next disease state is bipolar disorder. Recommendations for this disease state are very similar to epilepsy, so I'll kind of just group them together. Lamotrigine is really the only agent that's been determined to be safe during pregnancy. Lithium valproic acid and carbamazepine all have serious risks associated with them. Lithium valproic acid have more nerve and cardiac defects. Carbamazepine has been associated with growth abnormalities, and then fingernail hypoplasia, which is just restricted growth of the baby's fingernails. Now going into something a little bit more acute, asymptomatic bacteria or UTI. So why do y'all think pregnancy is one of the few, if not only, population where you treat an asymptomatic UTI? So ask Augusta.
We're not exactly sure, but it might have to do with the risk of getting a kidney infection and the implications that would have on the fetus.
Yeah, no, you're very close. So yeah, it's definitely has to do with the risk of an infection that gets progressively worse, because the complications from developing pyelonephritis, sepsis, bacteremia, worse infections, and hospitalization have a much greater risk than treating an asymptomatic infection, in this case UTI. So first-line drugs will include penicillin, cephalosporins, or beta-lactams. And of course, in our avoid column, we have fluoroquinolones and tetracyclines. Note this recommendation is very similar to our pediatric population. You avoid fluoroquinolones and tetracyclines in pediatrics as well due to chelation risk. That's very similar with a developing baby as well. In our limit column, we have nitrofurantoin and Bactrim, a little bit different than use and avoid. Again, it's benefit over risk for these two. So nitrofurantoin is really going to be used in the first trimester if there are no other options. Don't use it in the second or third. Bactrim's the opposite. You avoid it in the first trimester, but you can use it if no other options are available in second or third. And in pregnancy, the mom is at an increased risk for VTE, or a more hypercoagulable state. Our two options for VTE treatment or even prophylaxis are going to be unfractionated heparin or Lovenox, low molecular weight heparins. So this is a case where if you have a patient who's pregnant, develops a VTE, they may come into your pharmacy with a prescription for Lovenox. Note that there isn't really an oral form of Lovenox out there. So it's a great opportunity to counsel your patient on the importance of taking their Lovenox maybe twice a day. How to administer a sub-Q injection is a little bit different than your typical insulin sub-Q injection, and then how long you're going to treat it for. So typical VTE is going to be treated for 3 months. However, in pregnancy, you treat for the duration of pregnancy and for at least 6 weeks following delivery, for a total of at least 3 months. Then in our avoid column, we have warfarin. It's our classic category X, or as you can see in the pre-lecture, you know that's antiquated now, so it's just our avoid. And then DOACs are newer oral agents, don't have as much data in pregnancy, so the safety hasn't been determined there. Now moving back into our over-the-counter recommendations with allergies, cough, and cold. These columns, you have intranasal options, and then first-generation antihistamines are recommended over second generations. This is usually our go-to. So key counseling point with our first-generation antihistamines, which include Benadryl, makes the patient sleepy. Some moms may welcome this. During pregnancy, they may not be getting some sleep. However, other moms may be wary of taking something that makes them drowsy. And then additionally, look at the avoid column, hydroxyzine can be used for sleep as well. So this might be another opportunity where you say, hey, hydroxyzine's not safe during pregnancy. Have you tried a first-generation antihistamine? Can cover both your allergies and help you sleep as well. And so many over-the-counter formulations can include alcohol, and if you know how many times patients just buy based off the brand and don't even look on the back of the product to see if it has alcohol, it's another opportunity for us to kind of monitor and see if a patient who's pregnant has a decongestant or some cough and cold product that contains alcohol. It's an opportunity to intervene and provide some counseling. And guaifenesin and dextromethorphan I left off because they have some special recommendations and it's really OB specific. So they're safe in standard doses, however, excessive use should be avoided. Then following along with our over-the-counter recommendations of constipation. So in our use column, it really follows along with our non-pregnant recommendations, not much different there. However, in the avoid column, you avoid the magnesium and sodium salts due to potential electrolyte imbalances. And you also avoid mineral oil and castor oil. A little different because we don't use those in non-pregnant patients, so why would I bring it up in pregnancy? Does anyone know an old wives' tale associated with castor oil in pregnancy? What? Yeah, so castor oil has... Yeah, thanks for bringing that up. So there's an old wives' tale that if you take castor oil, it can induce labor. Probably not recommended. Don't tell your patients not to do that. It's not safe. Then going into GERD, you have first all the way down to third line options for your patient, setting up lifestyle, all the way down to our Pepcid as part of our H2RAs. One thing to note is our PPIs are in the avoid column. They're associated with major birth defects and should be avoided. And then another thing to note is our calcium-containing antacids do cross the placenta, and there's been observed increased intestinal absorption during pregnancy as well. So excessive use of Tums or any other calcium carbonate-containing product should be avoided. Then summing up with lifestyle modifications, of course, we should know, or at least what we're learning now, that you avoid alcohol during pregnancy. I advise smoking cessation if you have a female who is planning a pregnancy or is pregnant. And then obesity has been linked to greater birth defects, so advise weight loss if possible. And then very last, the do not eat list. So I'm sure we've heard that you avoid raw meat and sushi during pregnancy, really mostly linked to toxoplasmosis or salmonella infections and the risk of acquiring those. Then our deli meat, smoked seafood, soft cheeses linked to listeria infections, and that can potentiate miscarriages. Then lastly, fish with mercury. You have a risk for mercury accumulation, and that can contribute to greater birth defects as well. Then to conclude pregnancy, I've included a list of drugs that really didn't fit into any of the other disease states, but are important to note, keep in mind. So in the first one, we have, first row, we have isotretinoin. So that drug actually has a REMS program associated with it. So it's a great example of our new pregnancy category that includes individuals of reproductive potential. To get this drug, you have to have a negative pregnancy test because it has shown to be harmful during pregnancy. And then in the second row, you can see mifepristone, misoprostol. These drugs are associated with inducing contractions. And so if you're not going into labor, it's not safe to use at all. And then lastly, hormone products should be avoided as well. So to wrap up pregnancy, we'll go into our second case. EF is a 28-year-old female who comes to your clinic complaining of migraines that will not go away despite using Excedrin. Take about 5 minutes, and then we'll go over the case as we do it with births. think everyone's about finishing up, so let's go over the first question. So what do you suggest for symptomatic treatment of the patient's migraines? Let's ask Athens. I don't know if I've asked them in a while.
For pain, we would give sumatriptan.
Okay, you can give sumatriptan. Did anyone have anything different? So yeah, sumatriptan is one of the options. Could also do ibuprofen if it's been determined safe by the patient's provider. Acetaminophen could be used as well. Key counseling point for this is you have options out there that are safe using pregnancy, sumatriptan being one of them. However, it's important to consult with your OB and see what in your specific case is safe to use. Any questions about that? Okay. So moving on, are there any other disease states that you want to manage during this visit? Okay, so I see you nodding your head yes and Savannah.
I said for her hypertension, she's on valsartan, so you want to switch that to something like labetalol. And then also her diabetes, her A1C is still 8, and it needs to be at least 6.5, so I would recommend switching her to like insulin.
Okay. And then, was there anything else that someone did differently or wanted to add? How about adjustment? Oh, whoever that was, sorry.
For her diabetes, would we want to discontinue the metformin or just add the insulin to the metformin?
That's a good point. So I'll just go ahead and go to the next slide. So you could continue metformin and or initiate insulin. Really depends on what the patient prefers. If they want to just keep on their metformin and not take an injection, that's a good option. If they want to take insulin on top of their metformin because their A1C is 8 and you want tighter control, you could do that as well. Or if they are concerned about any potential risks with metformin, even though it is a safe option, you can switch them to a basal bolus regimen or start them off on a basal and titrate from there. With the hypertension, already answered that, so stop the valsartan because it's contraindicated in pregnancy. Suggest methyldopa, labetalol, any of the others that are safe to use. And then our preeclampsia prophylaxis, we can advise aspirin, 81 milligrams, really anything within our dosing range every day to prevent that risk. Any questions? Okay. Yeah.
Would you initiate propranolol for prophylaxis of migraine?
Yeah, you could do propranolol if you need something for prophylaxis, because that is safe. I guess I should have built that into the question. I was looking for more of an acute.
Would you tell her recommend not to take Excedrin because it has like, I mean, would that be recommended?
It depends on the patient. So, Excedrin, there's so many different formulations, so you have to pinpoint exactly what she's taking or which one and see what is contained within that. And then also see if her OB has recommended that product for her, or if it does eventually continue to work for her, see if it is still safe or on her do not take list. Does that make sense? Okay. So next question, what lifestyle modifications do you recommend?
Stop drinking.
Yep. What else? I heard good things in Savannah during discussion, so someone from here.
Avoid raw meat and seafood and deli meat and soft cheese and fish with mercury.
Yeah. And anything else? So, avoid alcohol. Our dietary recommendations: avoid raw meat, seafood, deli meat, soft cheeses to avoid that infection risk and any risk of birth defects. And then also physical activity as feasible. Yeah.
For the weight loss that's recommended, is that during pregnancy or after, like before, like if they're planning to become pregnant? Because do you want them losing weight while they're pregnant?
It really depends. So if a mom is planning on becoming pregnant, you can advise weight loss prior to pregnancy. If she's already pregnant and some sort of physical activity like taking a light walk or some low weight bearing exercises is feasible, you can recommend that as well. So it's really more patient specific, what the patient is capable of doing, and then also what their timeline is looking like. Are they pregnant now or are they planning on becoming pregnant? Okay, so that sums up pregnancy. Any questions about that topic before I move into women's health? Okay. So moving into our next topic, I split this up by disease states, starting off with oral contraceptives. Kind of a broad topic because there's so many different products out there, but there are some general drug interactions that you should be aware of, starting with our antibiotics, namely rifampin, also penicillins and tetracyclines. These drugs can reduce the ethinyl estradiol levels that you obtain from the contraception, rendering the oral contraceptive less effective. So does anyone know a way that you can counsel your patient if they're on both an antibiotic and oral contraceptive at the same time? Let's start with Albany.
You would want to use an additional form of contraception.
Yeah, so advise using an additional form of contraception for the duration of the antibiotic therapy and then for at least 7 days following discontinuation to ensure that all the drug has been cleared. And similar to that, but a little bit more permanent because you're not on anticonvulsants for usually a short term. Anticonvulsants like phenobarbital, carbamazepine, and phenytoin can also have the same effect by inducing estrogen and progestin metabolism, rendering the contraception a little less effective. And then the converse effect, contraceptives can reduce the efficacy of lamotrigine, thereby reducing the seizure threshold. The recommendations if you have these two interactions can be to recommend an alternative form of contraceptive. There's a depot shot that bypasses PO. You can also recommend IUDs, so anything that's not PO. Then lastly, drospirenone is an ingredient in some formulations of contraception. This drug has been known to increase serum potassium. So drugs like ACEs, ARBs, spironolactone, which also increase potassium if taken together, they can increase the risk for hyperkalemia. So that's another thing that you need to monitor for if you have a patient on both. Then under our contraception category, we have combination oral contraceptives. So these are pills that contain both estrogen and progestin. We have 3 different categories: the breastfeeding category, smoking in age greater than 35, and there are contraindications. So does anyone know why breastfeeding would be a contraindication with our combination products? Ask Augusta.
Estrogen reduces breast milk production?
Yeah. So if you're trying to breastfeed, but you're also on a medication that reduces breast milk production, kind of defeats the purpose. So you can advise progestin-only pill or like I mentioned in the previous slide, a depo shot, DMPA, dextroprogesterone acetate. And then similarly, these products can also be recommended if patients are greater than the age of 35 and also smoke, because you have an increased risk of MI, stroke, and then with our contraindications, similar risk. And then uncontrolled hypertension falls under this because combination products can increase blood pressure as well. And with additional hormone therapy, so kind of shifting gears, many patients might be on estrogens and progestins for symptomatic control of menopause, or they may be taking tamoxifen or aloxapine if they have a history of breast cancer. So with estrogens and progestins, you have contraindications very similar to the previous slide, a history of recent stroke, liver disease, or a history of VTE. In these cases, you can consider SSRIs like paroxetine or SNRIs like venlafaxine. However, you look in the second row, paroxetine and tamoxifen have an interaction. Does anyone have a guess as to what the mechanism of this interaction is? Samantha?
Does paroxetine inhibit tamoxifan's metabolism?
Yeah. So paroxetine will inhibit tamoxifan's metabolism to its active metabolites via 2B6. So in that case, you can recommend an alternative way of controlling their menopause symptoms. Say if they can take estrogens and progestins, that could be an option, but there are other options available as well. And then raloxifene, it's mostly going to do with, these interactions will mostly do with absorption or binding. So cholestyramine can reduce the absorption of raloxifene. And then it's also highly protein bound, so it interacts with warfarin. But in that case, you're already monitoring their IMR. If they get initiated on it, you might have to monitor their IMR a little bit more closely. Now moving to osteoporosis, I'll go over calcium carbonate. There is a citrate form available that has fewer interactions, vitamin D, and then on the next slide, bisphosphonates. Main interaction with all three of these drugs is absorption-based. So calcium carbonate, PPIs, and empty stomach can all reduce the absorption of the calcium. And then conversely, fluoroquinolones, tetracyclines, and thyroid supplementation can have their absorption and their efficacy reduced if taken with calcium carbonate. Then vitamin D has very similar interactions with rifampin, barbiturates, valproic acid, inducing its metabolism, and then cholestyramine, cholesterol, reducing the absorption of that drug. So in these cases, you'll counsel your patient to take the offending drug 2 hours prior to or 4 hours after taking either calcium or vitamin D. So I'll repeat that because it's very important. Take calcium carbonate 2 hours after or 4 hours before any interacting medication. Now going to bisphosphonates. Primary interaction, like I mentioned, is absorption-based. So whether it's food or another drug or even a liquid, bisphosphonate should be taken 30 minutes before really anything else. The only thing that bisphosphonates can be taken with is a full glass of water. So not even mineral water, juice, coffee, tea, because taking that with anything besides water can reduce the absorption and then the efficacy as well. That wraps up women's health and brings us to our last case. Before we move on to that, any questions? Okay, so take about 5 minutes and then we'll discuss. we're ready to go over the case. So VG is a 71-year-old female with osteoporosis. She comes to your pharmacy to pick up Alendronate, a new prescription, along with refills of other medications. So would someone from Augusta counsel me, like I'm the patient, on how I should take my Alendronate?
Are we supposed to be talking?
Yeah. We're supposed to be counseling.
Counsel on Alendronate. Go for it.
Go, Curdy. Just say take it 30 minutes before anything. You want to take the Alendronate 30 minutes before you take anything else, and take it with a full glass of water only.
Yeah, nice. So take it on an empty stomach, about 6 ounces or a full glass of water, first thing in the morning, and then avoid taking it with other medications by at least 30 minutes. Are there any other medications that you want to counsel the patient on?
Is that supposed to say vitamin D?
Get the essential silver. Reduce calcium. You picked calcium.
Calcium carbonate should be taken 2 hours before or 4 hours after.
So take calcium carbonate 2 hours before, 4 hours after, or the interacting medications? Yeah, so take any interacting medications with calcium carbonate 2 hours before or 4 hours after calcium carbonate. Been nice and written it down for you. Any questions so far on anything? Yeah.
I have a question in Athens.
Yeah, so how I've worded on the slide is you're going to take calcium carbonate 2 hours after the interactive medication or 4 hours before the interactive medication. Does that make sense? So if you have fluoroquinolone, you can take it and then 2 hours later you can take your calcium carbonate. Or you can take your calcium carbonate and then 4 hours later you can take your fluoroquinolone. Does that make sense?
Why would you say it like
And does that answer your question in Athens? I think Savannah and Athens have the same question. Any other questions? Okay. With that, I'll sum up the lecture with a few clinical pearls. Start out with rule out pregnancy. So we did this with our first 2 cases. As with any female reproductive potential, have to rule out pregnancy before you can determine drug therapy, because some drugs we may want to use or that may be preferred may not be the safest option. Then again, always have to weigh our benefits over our risks to justify therapy. So a drug may be perfectly safe in one patient, but harmful in another, dependent on their specific case. And third, Keep in mind, there's so many different hormonal contraceptive formulations. So if the patient has a contraindication to one, they may be able to take a different kind. So if they can't take a combination oral contraceptive pill, you have your progestin-only pills, or even the Depo shot available. So that leads into the fourth topic, or fourth point, alternative drug formulations may be available. And this is also true for bisphosphonates. So in addition to the daily formulations, there's also weekly and monthly formulations available if they can't separate out their bisphosphonate with other medications as well. And then lastly, always, and this is with any patient, pregnant or not pregnant, keep in mind any over-the-counter drug interactions or contraindications. You might not have their complete medication list whenever counseling a patient or providing recommendation. So it's always important to ask patients if they're taking anything over the counter when counseling them on a new prescription. That's the end of the lecture. I'll take any questions if there are any.
Can you explain the calcium carbonate spacing just one more time?
Yeah. So you're going to take calcium carbonate 2 hours after or 4 hours prior to any interacting drug. So the example I used was fluoroquinolones. So say they're taking levofloxacin and they take it, but then they need to take their calcium carbonate. They can take the calcium 2 hours after taking Levaquin. Or if they took their calcium carbonate and they need to take their Levaquin, they can take the antibiotic 4 hours after taking calcium.
She just said it wrong. She's saying 2 hours and then 2 hours after. Either 2 hours. Just choose the answer choice that says 2 hours and 4 hours.
Alright guys, as Dr.
What if she puts both on there?
Yeah.
She's like, so anytime I know it.
Or the exam that you're studying or will be studying for. So if you have questions about any of the lectures, please feel free to email me. If you need to, also my Dr. Bolino question from her section. If you need to email me, and I will get in contact with her. All right, so if you have questions, let us know.
Oh, I know, she's got it wrong. She's saying something wrong.
No, just this material is an onset.
Yes, that makes sense. But if you took your calcium carbonate